and welcome to Darold Miller Live here on the ZNS Radio and Television Networks. And we are streaming all over the world at www.znsbahamas.com. We invite Dr. Delon Brennen, Deputy Chief Medical Officer of the Ministry of Health, to lead us in prayer. Dr. Brennen.
Conversation to discuss bringing equitable health care to the people of your country, the Bahamas. We pray that you continue to hold us safe within your arms, to make sure that we bless those who are under our charge to be able to get that care. For those who are unable to participate in the way they would like to, that they continue to push and ensure that we get them the services that they need in a manner that does not present them with any difficulties in being able to do so. May we bring together those heads of and minds of those who are charged with doing this, so that we do it in a way that is pleasing unto you, and that we continue to bless you. Lord, bless those families who have been touched by tragedy in our country, so that we may be able to bring them some relief, because in these trying times, as we begin to celebrate the birth of your son, we will also begin to bring them the relief that they need moving into a new year. Lord, thank you for doing this, and in your name we give you thanks, for it is already done. Amen.
Amen. Thank you very, very much.
Absolutely.
Dr. Delon Brennen. Am I pronouncing that?
Absolutely, sir, you are.
Dr. Delon Brennen is the Deputy Chief Medical Officer in the Ministry of Health. He's here to talk about National Health Insurance, N.H.I. But before we talk about that, you know what we have to talk about.
Yes, sir.
What is that?
The tragedy of violence within our country, sir.
And specifically?
The incident that happened within the school children attending Doris Johnson, while not on campus, but still school children of that campus, and the stabbing death of a young 12th grade student.
Were you called to the scene or something?
No, sir, I was not. I heard about it on social media, as many people did, and then watched the news to hear about some more of the details, and then listened again this morning on the news about, the tragedy within the family as well.
I'm horrified. Describe it here.
Absolutely. It truly is unfortunate that, society as a whole, and we in the Bahamas, have gotten to the point where, for some of us, this is no longer a surprise. We almost expect that every day we're going to hear another story. And yes, there's a horrifying twist in being a 12-year-old young male, someone who is likely to graduate and become ideally a productive member of society and contribute back to society upon leaving school, and now that life is cut short. But what you also see is the tragedy amongst all of those who are now going to be affected, those whose lives are now going to be cut short because they were participants in this. They are the perpetrators of this violence, and the violence that was beget upon just the mental aspect of those who witnessed this type of event, and then the families from there. This is a cycle that at some point we have to take seriously enough to be able to break that cycle, because more and more those things aren't affecting us. We see nothing to sending it around on social media and glorifying it even more, because it's almost expected that, can I be the first one to send it out? Can I be the one that gets the scoop on it? This isn't something that we can take lightly anymore. We have to begin to address it, and no one sector of society, whether that is the health sector.
Begin to address what? Putting the things on social media?
No, not just that, but just the simple fact of the violence that's actually happening in our society, begin to address that. Because ideally, we have to get to a point where we no longer have those events occur, and when they do occur, we have an uprising about those events as well. Because we've become so conditioned to it that there's unlikely to be some big upheaval about this. We'll remember it for a week, maybe 2 weeks down down the road. But then do we continue to do something about it from day one into day number 10, day number 50, day number 365? A year from now, will we still be as upset about it today as we are right now? I fear that we will not be. But we have to find a way to do something about it. And it has to start with the people who are most affected by it. But it has to be our whole society that takes it and says, all of us. And that's what I mean, most affected, and then all of us who are affected as a whole. Because there's really only 350, 400,000 of us here. Every incident that is of this size should affect each one of us personally, because we know those families. We know either the individual or someone that knows them, and we have to take it seriously that we're going to do something about it.
You ever seen a knife that big?
I mean, in my kitchen, but outside of that, not on the street, I haven't. There's a way that didn't affect anyone to the point where we really are saying that is outside of the norm. It wasn't, people weren't surprised that it happened. People were it was glorified to that point, but people weren't surprised that something like that could happen. If you asked them 2 days beforehand, do you believe there could be a stabbing at a school, whether high school, they would say yes.
Because there's a fight breaking out outside just about every school in Nassau every day.
Absolutely. And it isn't societal and sociodemographically set up where it's only in those government schools or public schools. It happens any school in this country.
What is it about a group of children together, all coming out one gate, sometimes 1,000 of them? Because they all get ready, somebody coming to pick them up or to catch the jitney, they all got what? Is there some crowd dynamic that's injurious?
I think group or crowd dynamics are such that what happens within the group, whether it's from a leader or just the group mentality as a whole, will push the group into action, right? For whatever, good or bad. And that's one of the things you have to realize is you can use that same mentality, that same approach for good as well. Because I'll tell you, having been involved in groups that are good, let's say Boys Brigade, was in 30th Company of Boys Brigade growing up, and pretty much whatever that group was doing, and again, most of it for good, that's what I did. Because that's what we learned how to camp, we learned how to march and drill. Would I have ever done that on my own? Probably not. And where would I have learned it on my own? But because I was involved in that group and the dynamics pushed me in that way, that's what we did. The same thing happened with church youth group. The same thing happened with church choir. All of these things, once you're involved, if the group is doing well, you will do well as well. But the same thing happens on the converse. If the group is being pulled in a negative direction, then you, as a member of that group, will be pulled into that group, or what some people refer as to gang mentality, and the whole group of you will participate in such. And it's just innate. That's what happens to us as human beings. When it's like during Junkanoo or Independence, when the group is cheering, we all cheer. You go to the stadium, and when everybody stands up, everyone stands up to cheer. But the same thing happens in anything else. And we have to use that same thought process and same mentality to be able to get good out of our young people as well. Because that's really where it starts. No one decides that this is what they want to do. But if you put them in the right situation, they'll be able to consciously or subconsciously get along the right path.
Thank you. Do you know what this pin I'm wearing is?
Blue. With the heart on top. Pink is usually breast cancer.
I think that's
right.
What it is.
Okay.
This may be
it could be.
Else,
it may
I'm
be.
wearing it in honor of the great women of Eleuthera, who just came through a very successful Christmas tree lighting at the Cancer Society, Central Eleuthera, on the highway in Palmetto Point. They are raising money, along with the Rotary Club, to purchase a mammogram machine. As we now move into this portion of our discussion, looking at national health insurance. The first question I want to ask you, I know you're going to get into the details, but the first question I want to ask you is, will national health insurance help to reduce the incidences of breast cancer amongst the women of Eleuthera? And I say that because I want to pay tribute to those women.
Right. So the short answer to that is yes, in a way. The reason I say that is because what national health insurance aims to do is improve the health status of all people, including the women of Eleuthera in the country, while also protecting them financially from financial ruin or not being able to access those services because of the inability to pay at point of service.
So, the short answer to this one, I hope, is yes.
Yes.
Would national health insurance pay for the women of Eleuthera to go get that mammogram?
Absolutely.
Okay.
Even early on in the process, before we even have the entire benefit package that is likely to be rolled out over the course of time, the next year or so, early on when we address primary care, mammograms are a screening that need to happen at primary care, and that would be paid for and organized through national health insurance.
Now, off air, I said to you, this has become a catastrophe, and you looked at me. And then I said, political catastrophe. You want to take a stab at that before you get into the details?
No, I think the side when it comes to politics and the issues there aren't really my part of it at all. We really deal with the technical side of it and what it will or will not do. But the fight in politics and over PR for that really isn't, my gamut at all.
But here it is. Christmas right around the corner. January 1st right after that. And you starting this thing January 1st and you just reach.
Agreed, sir.
I put my question back to you. Is this a catastrophe?
And so technically from our side, I would still say no, this is not a catastrophe. I think for the entire time that you would have thought that we should be doing the public relations related to it, and that we may have advocated for doing the public relations, while not necessarily being able to do so, we have been doing the work required to be able to design the program so that it would still accomplish the same things that we would want to go along with it.
Obviously, the politicians calling the shots.
You are right, sir. They do.
Okay. What is national health insurance?
So national health insurance is really just one part of what it is that we would like to accomplish in country in improving the health of our population. What we are doing, along with all industrialized nations and all first world nations, but along with the developing countries of the world, so both from the United Nations side and the World Health Organization, is instituting a system of universal health coverage. So when we talk about universal health coverage, there are really four pillars to that universal health coverage. Number one is governance and stewardship. So the governance of the system is making sure that you actually pay attention to what it is that you're doing. You have direction to what it is that you're doing so that you're not just flailing and things happen haphazardly, but you have an overall overarching structure that is put in place to make sure that those things that you want to accomplish, the improvements in our healthcare structure, the improvements in the health of the people, and the protection of them financially, that we have mechanisms to pay attention to that as we do it. So one is governance. Number two is strengthening of the health system. So you need to make sure that the health system we present to people right now isn't what they're going to get once you put the system in place. And so a year from now, you shouldn't be still looking at the same health system. 10 years from now, you shouldn't be in the same health system. A generation from now, 20 to 30 years from now, you shouldn't still be looking to say, right now, what we have right now, it's very similar to what we had 5, 10, almost 20 years ago. But leaving from right now, 5 years from now and 10 years from now, you should be able to feel, see, touch a different healthcare system than we have in place right now. So that's pillar number 2. Pillar number 3 is really what we talk about is the financing part of universal health coverage. The Bahamas has decided that what we are going to do is institute a system of national health insurance in order to finance it. This is a proven system that has been put in place in many other countries as well, but it is not the only way that you can finance the health system. You can do it through other means. You don't need to have national health insurance. You can have general overall taxation that takes care of it and just, have higher overall taxation and then use those funds to be able to fund healthcare through the system as well, universally. But we've chosen a different method so that you can actually see that any funds that are actually collected specifically for health go toward the delivery of health. So that's probably one of the biggest reasons for choosing a national health insurance program in order to do it. Fourthly, if you were to improve the governance of the system, you were to have an improved healthcare system as a whole, and you were able to finance it. It's like having a 4-legged stool with one leg missing. You would still have 3 legs, but you still wouldn't be able to sit on that stool appropriately without the 4th leg. The 4th leg is the social determinants of health. And when we say that, what we really mean by social determinants of health is all those other things that contribute to your health that have nothing to do with the health system. So when you talk about the food that you eat, your general overall security, the simple fact of if we wanted to, let's say at nighttime, wanted to take a walk, right? And you wanted to go anywhere in the country, you just wanted to be able to walk for your health. Would you feel safe in doing so? Would you have a sidewalk to walk on? If you decide to take a bike, do you have a bike lane to ride in? All of those things contribute to your health, but honestly have nothing to do with the health system. The types of foods that are available to you and the cost for those foods, those have something to do with your health, but the health system doesn't control that. But that is a part of universal health coverage. So bringing all the players in and contributing to the system is why we know that this system will work and can work in country, because you take all of those parts and put them together. So while we spend a lot of time and a lot of effort focusing on national health insurance is really just the financing arm and the catalyst for getting all those systems in place to move us toward universal health coverage.
You call it UHC?
Yes. So we want to move toward UHC. Now, national health insurance, as we know, is really the financing arm to get us there. It finances the improvements in health system. What it does, it also helps to finance some of those improvements in the social determinants of health. But it brings to the fore the need for those improvements in those social determinants as well. It also brings to the fore that the governance that we had in place before has not worked. I think we can all admit that the health status of our country is poor. It just is. And it isn't because we haven't spent money on it. It is because we haven't put all of the systems in place to ensure that those quality measures are in place. We're focused on the health of individual patients, of families, of communities, and of the country as a whole, to making sure that we move those health indices to getting us healthier. And we move those things like our rates of obesity, our rates of diabetes, our rates of infant mortality. We have to be focused on those in a way that it's comprehensive and it's targeted in a way in order to bring those things down. But because we sort of have siloed a lot of things, so we have a program for this, we have a program for that, we have people addressing in the non-governmental sector cancer, we have another set of people doing heart disease, we have another set of people doing diabetes. But the problem is those aren't coordinated by any particular mechanism. But we do know that what we eat and our level of obesity affects heart disease, it affects diabetes, it affects cancer. So the way to do that is to bring all of those pieces together so that we have one focus on how, based on evidence, based on quality evidence that says we are going to address it in this way. That way, everyone's particular issues are addressed, but nationally, we're addressing it in a coordinated manner in order to get us better. Because if we continue to do it the way we're doing it, we'll continue to fail. Because that's what you know. Insanity is that continuing to do the same thing you've been doing and expecting a different result. And honestly, we've known for a long time that we needed to eat better, that we needed to exercise. Have we improved our health just being able to tell people that? No, education is not the only answer. It is a part of the answer, but you have to do all of these things in a coordinated manner based on evidence to get us to where we need to be as a healthier nation. And this, if we can call upon national health insurance to do one thing, it would to be that catalyst to get us to that place. And that's much more important than the financing to go with it. It really is forcing us to get to a healthier Bahamas. And we have long said, and a part of the Nassau Accord and the Nassau Declaration says that the health of the nation is the wealth of the nation. We have to believe that. And if that is true, and we believe that our economic survival is based on how healthy or unhealthy we are, then it'll change the conversation altogether. Wealth no longer becomes the focus. Health becomes the focus because good health will get us to good wealth. But worrying about the money first won't get us to good health. We have to change the way the paradigm is set up at present.
Can I tweet that?
Absolutely, sir.
Our economic survival is based on how healthy we are.
Absolutely.
We're going to go to our first break, but I think I'm buying into this.
I'm glad to hear that, sir.
I got to look at part 3, though.
No problem.
Financing of this UHC, Universal Health Coverage, the financing of N.H.I.
Yes, sir.
That's what we have to look at. Let me say now, though, are you in charge of this?
I am one member of the team who's working on this, sir.
Are you the lead member of the team?
I am the project manager for the National Health Insurance implementation
You're in
team.
charge. You are in charge.
I will take that we work as a team, and I am the project manager for it. Yes, sir.
So, if it fails, it's on you.
I will take some responsibility. Yes, sir.
If it passes, it's on you.
No, it is on all of us if it passes. If it fails, I can take some responsibility for that.
Then I heard, hey, Robert, you should see. You see it? You look sharp. Sharp. When I heard you were coming on the show, I had to go by KS and look for something because and I gotta get this one out of the way fast because you're smart mentally and you're smart in your dress, and so I thought I would go by KS Moses. Listen, guys, KS Moses hooked me up.
You do look sharp, sir.
Yeah,
you do look sharp,
thank
sir.
you very much. They hooked me up and they said, Mr. Miller, spread the word. It's Christmas time. The guys gotta look good because when you look good, you feel good. And say, we got this special going on right now, the whole thing, down to your socks, your belt. Ask for the Darold Miller special at KS Moses. Be in the islands. Call 322-7707 or like KS Moses on the Facebook page. Check it out. We'll hook you up. We'll find a way to get it to you if you can't come to Nassau. You gotta look good this Christmas. They have, man, a special that's unbelievable. The matching tie and the pocket piece, good suit, 3-piece, socks and shoes, new handkerchief, everything. They hook you up really, really good. Tie pin,
Cufflinks, yeah. Don't worry, you know I do cufflinks. Don't worry.
So check them out. Tell Steven and the girls you heard this ad on Darold Miller Live. Make sure call my name. They're gonna take it. This is Darold Miller Live. We'll be back right after these messages. Welcome back to Darold Miller Live here on the ZNS Radio and the television networks. Our very special guest today is Dr. Delon Brennen. He is the Deputy Chief Medical Officer of the Ministry of Health. The Chief Medical Officer is Dr. Glenn Beneby.
But I will say that in particular, the activities that we're doing sprung out of the Ministry of Health and are now led in the Office of the Prime Minister under the National Health Insurance Secretariat, which is led by our permanent secretary, Mr. Peter DeVoe Isaacs. And we have an entire team of well-qualified personnel that have been brought on in order to address this as well. And in every aspect, we have, great people and great professionals who are helping us to take care of, those nitty-gritty details of national health insurance. So I definitely want to say thanks to the team that this is no one-man effort. It is all of us who are contributing.
So you've been seconded?
Yes, sir.
To the Office of the Prime Minister?
Yes, to the National Health Insurance Secretariat.
National Health Insurance Secretariat, which is in the Office of the Prime Minister?
Correct. Yes, sir.
So this is the Prime Minister's baby?
Yes, I would venture to say that it is a part of the political directorate's lead to be able to make sure that we get this accomplished. But those other agencies are definitely involved. Mm-hmm. So, like I said, it came out of originally the Ministry of Health and the leadership of the Minister of Health, and the Prime Minister is now a part of the Cabinet subcommittee that helps to lead that. But other agencies are involved: National Insurance, Ministry of Labor. So it isn't just us, mm-hmm. Who are involved, but realizing that this is a national level initiative. It is likely to be something that people see, touch, and feel going forward for generations, much like none of us would want to get rid of national insurance as it is now. You see other instances in other countries like Canada, the UK. You cannot touch their national health insurance or national health services. As much as you hear people argue and debate about
politicians can't touch it.
Politicians know. It would be political suicide to get rid of or even intimate that you were going to get rid of national health services or universal health coverage in those systems. Once they're in place, the people start to feel the difference of having a system that is protecting them, not just their health, but also financially from financial ruin, and being able to address what it is they need individually. So this is something that I think when we talk about this a year, 5 years, 10 years down the road, you will see where this is something that we will hold near and dear to us as much as we hold near and dear to the flag and to the yellow elder and the flamingo. We will hold near and dear to this in a similar manner once we buy into the fact that this will get us where we need to be as a healthier nation. And I honestly believe, and I've heard our chief medical officer say this, and I truly believe the simple fact that this can get us to being, if not among the 10 most healthy nations in the world.
Where are we now? 100 and...
I don't know. It's hard to be able to say individually, but I know we have really high rates of diabetes. Statistics have said that we have one of the highest rates of diabetes in the world.
And obesity.
Obesity, while not a disease, more a risk factor, we have one of the top 10 rates of obesity in the world. And I think programs such as this that really help us to bring focus to the health of the nation and make us change what we've been doing can get us on the exact opposite side to being one of the 10 healthiest nations, if not the best.
Okay. First of all, let me alert you, you're not leaving the show early. You're going to be here until the end. The last time I think you had to leave, but you're going to be here until the full extent of the show, because we're going to have a few more questions, and then we're going to open up the lines.
Okay, no problem,
for
sir.
Persons to call in wherever they are. The way I understand the Prime Minister saying this is that national health insurance, universal health coverage, is not going to cost me anything right now. Maybe $1 or $2 later. Is that your understanding?
That is my understanding as well, sir. So based on government revenue that's already brought in, there are not going to be any new taxation, any new charges once we roll into this first phase of national health insurance. I think what we want to make people understand is that All the things that have been asked for and begged for, both from the populist side and from the stakeholder side, we've taken into account and said, what we want to be able to deliver is an improvement in the healthcare system, an improvement to the way people access the system. We want to make sure that people start to see and feel the difference that N.H.I is making long before they have to feel as though anything new is coming out of their pocket to be able to pay for it.
So, when do you see people paying something? A year from now?
Sir, I honestly do not know and cannot say, but what I will say is the impetus to us and having charges being added, whether it's through employee contributions or anything of that sort, is really much more something that's in the hands of the Bahamian people than it is in the hands of the political directorate. And the reason...
Hold on, wait a minute. Sounds like you ain't doing nothing new then.
No,
that's what I have now.
No, sir, it isn't. Absolutely not.
I have universal health coverage now at the Princess Margaret Hospital.
Not at all, sir. Not at all. I would venture to say, and again, remember we're talking about primary care. So the Princess Margaret Hospital is mostly involved in secondary and tertiary care. So when you need a specialist service, you need to be admitted to the hospital, you need surgery. Those are secondary and tertiary care services.
Clinic give me the primary care.
So the clinics give you primary care, right? But what you would find out is that you are, in general, you need to present funds at the time of service to be able to access that care. There is a service charge. Now, whether you decide to pay it or not may be different. But as a Bahamian citizen, if you are not found to be indigent, if you're not a child, or you are not a pensioner or elderly, there is a charge for that service. And it's not just the charge for the visit, but there are charges for medications. There are charges for screenings and labs to be done. All of those things are charges that are incurred by the populace. And in fact, those are charges that people will not come to a service for because they can't afford it. It may be small. People may consider the $10 for some small, the $30 for others to be small. But honestly, there are people who do not access the services because they cannot afford it. We also tout along the way that services for women and children are free of charge, right? But if you are pregnant as a woman and needed to have an ultrasound done, you needed to have prenatal labs done, you needed to have medications done from the facility, even in the public sector, those things are not free of charge. Those things are not included in the services that are presently provided free of charge. Those are the things that are being eliminated from the system. We need to eliminate those user fees at point of service so that everyone feels as though they have access to those services. But in addition, the crowding that happens both at the Princess Margaret Hospital when you need to access some of those services, at the clinics when you need to access those services, that's a part of what we're trying to eliminate as well. So changing the system, when we talk about stewardship and governance and being able to introduce a system where you have an appointment-based system. So you have the respect of the system that says, I respect your time, I respect you as a person. I'm going to deliver care in a manner that allows you to come in, much like you do in the private sector, and have an appointment for a service. And I don't have to dedicate my entire day. I don't have to show up at 6 o'clock in the morning and get a number and wait my entire day to get a service delivered to me. I can get an appointment, and I know a week from now I show up at 9:30 in the morning, and I know I may be there for an hour, maybe an hour and a half, but I have the service delivered to me in a respectful manner and a timely manner to get that done. But what National Health Insurance adds, even on top of that, is the simple fact that we consider this an entire health sector. So it's not just that we are forcing people to go into the public sector to get all their services. What we're doing is saying those services that are approved. So when we launch with primary care services, those services can be delivered not just in the public sector, but if your private provider says that they want to be a part of national health insurance or universal health coverage in the Bahamas, then National Health Insurance will pay your private provider for providing you that primary care service as well. And if you need to have labs done in the private sector, and that laboratory has decided that they want to be a part of N.H.I. and will accept the fees that N.H.I. has agreed to pay, then you can go to the private sector lab and get it done. Same thing for radiology services. Same thing for a pharmacy, like the National Prescription Drug Plan.
Walk-in clinic.
If the walk-in clinic decides that they want to be a participating provider in N.H.I., then yes, N.H.I. will pay the walk-in clinic to take care of you
So you
for
could
primary
give me a
care
card,
services.
something like this Mango Flash Cash card. You would give me a card, something like this.
So because we're launching as soon as we're launching, the expectation is for people to be able to use their national insurance card for them to be able to access those services. So you won't need a new card to do so, but for those
Hold on.
for the
don't mix this up with national.
No, I'm not. I said you'll be able to use your national
Many
insurance
people don't have
card,
a national insurance card.
and that is an issue. You're right. So just like you would have to be able to, in order to register for N.H.I., you would have to go through a process. What we're doing is trying to streamline the process and say, once you are able to register with national insurance, then we will have that
I am
information.
registered with national insurance, and God knows I don't know where the card is.
You need to get your card. You need to have your new smart card from national insurance.
Sure you want to mix them two up? This is a whole new baby.
It is a new baby, but sir, if we expect that we are going to consolidate services and be able to get things done efficiently and not just introduce a whole new level of bureaucracy and expense to the service.
That's a new level of bureaucracy you have there.
I think we're actually minimizing the amount of expense, administrative overhead, and bureaucracy by saying you can use the same
National
card.
insurance might tell me I can't get a card because I didn't pay. Them. That mean I ain't gonna get my national health insurance?
National insurance doesn't say you can't, as long as you're eligible for national insurance, you can get your card. Just because you haven't paid doesn't mean you can't get your new card.
I just don't want national insurance delay my national health insurance.
I agree with you. We don't want that either, sir. And at some point, the two will separate from each other completely so that the Bahamian people will be able to see that separation. But if the expectation is that we can take advantage of the things we currently have in country and not have to delay the introduction because we have to wait for a brand new IT system, a brand new card system, then we can take advantage of that right now and be able to deliver the service right now.
Okay, so I take my national insurance card to the walk-in clinic. And what I would have paid the walk-in clinic $500 for, why you laugh?
I can't say what their charge would have been, but I'm taking that.
National health insurance will pay it for me.
Right. So what will happen is you'll be able to access the service from the walk-in clinic. If you decide, I want to get primary care services from the walk-in clinic. So we have to be very clear as a people as to what primary care services are. So those things that you would go to your GP, your family medicine specialist, your pediatrician, your internist on an outpatient basis to have delivered to you, and those medications that are associated with that outpatient care, not higher level specialty care. We're talking about outpatient services, outpatient screenings, the things you would need to get on an annual basis, like mammograms and pap smears and prostate tests. You know, you need to have an EKG done. You need to have your cholesterol checked. Those sort of things that you would get in an annual physical, things of that sort, or minor illnesses and injuries that you would go to an outpatient center for, those services will be covered through primary care at those facilities that sign on to be participating providers in national health insurance. And if the walk-in clinic is one of them, and they say, we want to be a part of N.H.I. and we want to accept the contracted and negotiated rate at which N.H.I. would pay us to be able to deliver a service for you who has signed up with us, then National Health Insurance will pay them for taking care of you for that service that previously you would have paid for. And in addition, even for those people who have health insurance and would have had to pay for that service, not necessarily the full thing, but they would have had to pay either a copay or a deductible for it, National health insurance will pay the entire thing, and there'll be no copay or deductible, so that when you present for a service, you still don't have to worry about coming out of pocket with money to pay for even a part of the service.
I see why the insurance company's up in arms.
I can understand where they may have some trepidation, but the way this has been designed, they have been taken into account to be full participators in the service as well.
Why should I pay private insurance if national health insurance is free
And we
or minimal?
So what we have proposed is that many people feel as though they are comfortable with private health insurance, right? And so what we have said is, if a private health insurance company decides that they want to participate in national health insurance, and you sign, and then you say, I want to sign up for national health insurance benefits through that private health insurance company, then N.H.I will pay to the private health insurance company for administering your benefits. So they may provide you with additional benefits to go along with it. They may have a health and wellness program. They may provide you with discounts for particular services, that kind of thing. And they coordinate and deliver the payment for your service directly to the provider. So the private health insurance still gets paid for...
But that's peanuts.
It's not necessarily peanuts. We would have to negotiate on what they would be paid as an administrative charge for administering your service. Because technically, that's what they should be doing right now, is they get you the service that you should be delivered, right? And they would retain an administrative charge for delivering your services. It's no different under national health insurance.
Let's come back to the walk-in clinic example. This service that I'm getting, primary health care at the walk-in clinic, now I go and I pay $500. Are you in national health insurance going to pay them the same $500? Because it sounds like you're saying you might negotiate down.
We would hope to negotiate down from that level. And the reason I say that is because now we're presenting them with an opportunity to not just have you who pays out of pocket and can afford $500, or someone who has health insurance and their health insurance company pays $500. We're now presenting you with the opportunity to access all of those people of the Bahamas who currently don't have $500 or don't have health insurance. So the volume will increase for them, so they will get much more money coming to them because more people come to them as well who can now afford, through national health insurance though, to access their services. So yes, we would expect that it would bring down the per person charge, but they still get the windfall because they have so many more people who can now access their services who never could have accessed those services before.
Call your mommy, your daddy, your brother, and your sister, your auntie, your cousin. We're talking national health insurance today. It affects everyone. Dr. Delon Brennen, the Deputy Chief Medical Officer of the Ministry of Health, now seconded to the National Health Insurance Secretariat in the Office of the Prime Minister, is our guest. You have brilliant answers. I hate the politicians sometimes when they give you these runaround answers. You have brilliant answers. And what I like is you ain't got no paper in front of you.
No, sir.
You study this thing.
Absolutely. Working hard on it for the Bahamian people, sir.
Still a lot of questions, though.
Yes. Here to answer.
Will you give me free, under N.H.I, a quadruple bypass heart surgery?
So when we first launch N.H.I, the answer honestly to that is no. Because we're launching with...
Stop.
Wait. You won't allow me...
Let me die.
Wait, you're not allowing me to answer the question. Let me answer the question. So initially we're launching with primary care services. But under primary care, quadruple bypass surgery isn't included. But an improvement in your primary care will lessen the number of people who will require it. Now, when we get to primary care, and you get more people who are involved, we know primary care will also help to identify people who are sick and will require things such as bypass surgery. On rollout, we will also have, and there's a commitment to have funding available to be able to afford things such as invasive cardiac procedures. So for those who are found to have a need for those types of procedures, there will be a fund to get them those services as well. But I don't want to mix the two up and people believe that primary care will deliver it to you. That extra
So we know what
fund.
primary care is.
I
That's
just wanted
the
to
little
make
clinic
sure.
To do.
What, yeah, okay.
Simply put.
Simply put, yes.
Primary care is the clinic.
Yes.
I talking about
Public
in the
and private.
hospital now.
Yes.
The major secondary care.
Secondary and
I
tertiary.
lay down on the bed. I need heart surgery. You saying you ain't gonna pay for that?
No, I said primary care services won't pay for that, but there will be a fund through National Health Insurance that has been identified and agreed to be able to pay for that. So yes,
Let me ask you a
N.H.I.
question again.
Sure.
National health insurance begins January 1st.
Yes, sir.
February 1st, I need quadruple bypass heart surgery. Would national health insurance cover it?
So let's talk.
Yes or no?
No, we're going to talk about timing as well, right? So National Health Insurance launches in January with registration of the population. Upon registration, you don't get services immediately. As you can imagine, we need to get everyone signed up. So the first quarter of 2016.
Let's go to May 1st then.
All right, well, let's go.
Will you cover me in May 1st?
So when we start actually delivering services, let's say it's May 1st. As an example, if we start launching with services in May 1st, and through primary care, it is identified that you need an invasive cardiac procedure, there will be a fund through N.H.I. to pay for your invasive cardiac procedure. So in that instance, the answer is yes, there will be funds through N.H.I. to pay for you to have your procedure done.
If I hear you correctly, government could go broke.
I don't feel that way. I think what we
Because you ain't collecting nothing yet.
Not yet, but you realize that the government spends almost $400 million per year on health care already.
But that ain't on the procedures, that's on paying you.
No, that's on procedures.
That's salary.
Not just salary. That
The
includes.
salary is the biggest part of the
Oh,
budget.
absolutely. In any budget.
So if government spend $400 million a year, you could take 200 of that out right off the bat. That'd go to nurses and doctors.
But to do what?
You mean
To
what?
deliver service. That's who's going to be delivering your
But now
procedure.
you're saying all of these expensive procedures will now be covered. This must be a big fund you have.
No, it isn't a huge fund. What it is saying we have to do both. We are dedicating funding to be able to deliver good, not just good, great quality primary health care, right? So that we identify those people that are healthy so that we can keep them healthy. For those people who have latent disease and we keep them from getting sicker. And we also help to identify those people who have been previously unidentified as having high-level disease and need to have an intervention done to keep them alive or keep them from getting worse. When you do that, you now shift the focus to keeping a lot of people healthy so that they don't progress to getting sick, so that you don't get more expensive as you go along. But in identifying that, we know basically through our providers and through our own information, our providers have said that we are going to identify a lot of sick people. And in doing so, there has to be funding made available to take care of those sick people because not everything can be handled in primary care. We have listened to our medical providers and said, we will ensure, or the political directorate has said and listened and said, we will ensure that there is funding available to take care of that as well. If we identify that there needs to be more funding for that, then that will be the pressure to increase that funding. But right now, none of us know how much that is going to be. So they will set aside an amount right now to say, all right, during the first quarter, This is how much we think it might be. But if we run through that very quickly, then it may need to be increased. That will add some pressure to the system, but it'll also push for efficiencies in the system, improvements in how we do, reduces in wastages. That reduction in wastages, that is what we will have to do. But we can't pretend as though we are just going to cover sick people being sick in those procedures and ignore primary care, because what you do at that point is relegate everyone to waiting until they get sick for you to introduce something to take care of them. And that's what the prototypical catastrophic fund does, is it waits until you get sick and now I'll take care of you. We have to put our money where our mouth is and say, we are no longer going to wait until the Bahamian population is sick to give them the care that they need. We are going to introduce and put money into keeping people healthy. And when we do that, the countries that have done that have shown they've improved in their potential years of life loss, they've improved in their overall productivity, and they've improved in their GDP. It has come down to economics, where those who have good to great quality primary care have improved the productivity and the overall economics in their country.
Our very special guest is Dr. Delon Brennen. He says our economic survival is based on how healthy we are. And as we go to the break, I can tell you, if you want to remain healthy, you should eat good food. Finley's Seafood, wholesale and retail, is now offering you free delivery to your home or your restaurant. They have this freshly frozen seafood, grouper, lobster, conch, snapper, black and white fry, natural salt, dried and jelly coconut, all good things. Doctor?
Yes, sir.
And no cleaning or prepping needed. It's ready to cook. Call this number, 429-3071. 429-3071. Unbeatable prices, the lowest in town. Tenderized conch. Grouper filet, you got a little processing. Yeah, man, cut them grouper fillets like grouper steak. This is real good. Freshly frozen seafood. They located on Carmichael Road, but you don't have to go there. Just call the number. Tell them you heard this ad on Darold Miller Live, and Brother Finley will deliver it to you today. 429-3071. Finley's Seafood, wholesale and retail. What kind of doctor are you?
Pediatric emergency medicine.
Children.
Yes, sir.
This is Darold Miller Live. We'll be back right after these messages. Welcome back to Darold Miller Live here on the ZNS Radio and Television Networks. Dr. Delon Brennen is here with us, and hopefully they're not working you too hard. You'll have time after the show to go get some good soup from Divine Cafe. You do the soup?
I do like soup, sir. I don't think I'll be able to today, but
You busy?
I'll take you up on the offer at some other time.
Burning you out?
No, sir. No, just working
Because
hard.
January 1st right around the corner.
Hard work
So
ahead.
you got to do the PR for National Health Insurance all over Christmas.
Hopefully not just PR, but actually do some technical work at the same time, sir. Yes.
Mm-hmm. And again, when do you see us paying? You say it's free now. It'll be free starting off.
Yes.
When do you see us paying?
I think that is, and I think what I was saying before is it's in the hands of the Bahamian public, because I think once we roll out the primary care services and the fund for the invasive procedures and invasive needs, then I think we'll start to gain some momentum as to what people see is possible through national health insurance. But at some point, the reality is going to kick in for us all that if we want that next level of care, if we want more things to be added, that we are going to have to need to pay for it. There is no such thing as free lunch. We're going to have to pay for it. So
Well, the lunch is free now.
it isn't free because it's coming out of what we already expend through payments in the system already.
Taxes.
Yes, the government only has revenue through taxation.
Right.
So we're already paying for it. So it's not free. But it isn't any new taxes being added onto it. So we're just reapportioning some of what we're already spending in order to accomplish what we do in the first
So
phase.
you can't answer that question.
No, sir, I absolutely
When
cannot.
do you see us paying something?
I do not. But I think the Bahamian people make that choice. I think we say when we want
Before
more,
the election or after the election?
if we want
Take a
more,
stab at
if
that.
we want more before the election, then we should ask for it. If I had the opportunity, I would say
When you say-
we should
when
ask
you
for it
say
before.
Ask for more, you mean
If we
it
want
may
more
only
services.
remain in the primary?
If that's
care
all we
level?
want. If that's all we want, that's all.
So all what national, are you saying to me all what national health insurance will do is take care my bellyache, but not my heart?
No, I think your heart is also taken care of at primary care.
No,
but
because I didn't pass primary care. I laying on the bed now.
Right.
I laying on the hospital bed.
Mm-hmm.
You saying it can take? Explain that. I'm not following you.
Right. So the primary care, you think we have a good understanding as to what primary care is: outpatient services,
Clinic.
medications,
Primary
labs.
care clinic.
Right. So outpatient stuff will be taken care of. There will also be a fund for things that have been
When will
identified.
that fund for invasive come?
That fund will be expected when we roll out primary care, that there will be a fund for those things to happen as well. Right? But that's not everything. Your entire hospitalization, all the high-level CT and MRI, those medications that are needed for chemotherapy and radiotherapy, the full gamut of everything that we could want out
Not
of a
coming
service
now.
is not going to come now, right? Because
My question is, when will it come?
when we decide that that's what we want, because we're going to have to pay for it. We have to have the realization that when we want that service, we are also signing up to pay for it as well.
How much will we pay when it comes? You don't know that either.
No, there's projections for how much it could cost. And we're projecting that no more than 3% of contributions from employees will be required in order to do that.
And how
So
much is that?
what we pay right now through national insurance is 9.8%, right? There is an employer and employee contribution. The employee maxes out at about 3.9%. There's a ceiling, of course. If you make anything more than $600 per week, then you've already hit the ceiling and you can't pay more. Or it's about $2,467, if I remember correctly, per month. If you make more than that per month, you hit the ceiling and you don't pay more than that. So you actually paid less than that 3.9%. But let's say we max out at 3.9%. N.H.I. is likely to be no more than 3%, and that would be split between
3%
employer.
of what? My pay?
Yes.
That's a payroll tax you bringing me.
I'm not saying it wouldn't be if you want to consider, but what we're saying is 3% split between employer and employee. So the employee wouldn't pay anything more than 1.5%.
So there will be a new tax eventually.
Eventually, when we say we want more service, there will be a tax. But that's something, and I venture to say that when we start to see and feel what it is that N.H.I. is at the beginning, and then what we can project it to be in the future, that we will voluntarily, as a people, say we want to have it, so we are willing to pay for it.
This sounds good. And I need the public to help me out here because I believe there is a camouflage to be uncovered in all of this.
I agree with you, unfortunately. I agree there is a camouflage. But I think our camouflages are different.
Yeah.
I absolutely think so.
325-5405 is the number here in Nassau. From Eleuthera. Crooked Island. It's toll free. 1-242-300-8255. Send me messages, WhatsApp, text, 447-9879. We are going to tweet what Dr. Delon Brennen is saying. Our economic survival is based on how healthy we are. He also says we have to put our money where our mouth is. We're going to put those on our Twitter account, @MillerDarold. Follow us on our Facebook page, Darold Miller Live. Telephone numbers once again, as we begin to take questions for Dr. Delon Brennen, the project manager for National Health Insurance. 325-5405 here in Nassau. In the family of islands, toll free, 1-242-300-8255. A lot of questions have not been. Are you going to have a town meeting? A series of town meetings?
Absolutely, sir.
Are you going to take me or another around the country?
Yes, we are going to, starting next week, launch in earnest our communication strategy and our public relations strategy to be able to engage no longer with only the stakeholders within this from the industries, but also the public now. We have long spent time, and whether they admit to it or not can be a whole different series of conversations, but we have engaged with stakeholders within the insurance industry, stakeholders within the unions, with the Chamber of Commerce, with the medical providers, not just physicians, but other groups of medical providers, allied health professionals. We have engaged with them over some of the details that go along with national health insurance, from principle first to then some of the finer details. And we're continuing to do that. What we want people to understand is national health insurance and what you see launched in January of 2016, or when we deliver services in the second quarter of 2016, isn't the end all and be all of national health insurance. There are systems out there that have continued to evolve for the next 5, 10, 15, 20 years. The UK has had it post World War II. In late 1940, I think it's 1948, they launched a National Health Service. And you still see tweaks being made to that today. We need to start. We need to get launched so that we can make the improvements that people see a need through the system. But if we continue to mire ourselves in this rhetoric of we don't think it's good enough, we think we want to have more in the system and other people, if we continue to fight ourselves on this, our health status will continue to decline. And that's all we've been doing. Our infant mortality rate has gotten worse. Our maternal mortality continues to suffer. Our rates of obesity and heart disease and the levels of people that are dying unnecessarily every year due to those diseases are being affected every year. We have a chance, this you might call a watershed moment in our history, to be able to introduce a system to make market improvements in the way we deliver health, not just health care, but health to the Bahamian people. And we needed this a generation ago.
Under national health insurance, fully functional, there will be no need to go on Western Esplanade and have a cookout in aid of Wendy's medical expenses.
Not for health care. You may decide that you just want to have it for something else, educational funds, to get together. But health care,
primary and secondary,
and tertiary,
invasive and evasive, everything covered.
Essentially, it'll be a comprehensive set of services that will deliver the health care we need to the population of the Bahamas.
Let's go to, who we go to first, Ronald? Catherine. Hi, Catherine. She's not there. Wendy, are you there?
Yes, sir. Good morning. How are you?
Okay, turn her up, please.
Hello?
Yes, go ahead.
Okay, good morning. How are you?
Turn her up. We can't hear her.
Can you
Go
hear me
ahead.
now?
Go ahead, Wendy.
Hello?
Yes, go ahead.
Okay, I think that we are placing too much emphasis on the national health insurance. we're not placing much emphasis on the healthcare system in terms of the way we are being handled under the healthcare system. I mean, and if we're going to overhaul the system, we need to start from within the hospital. I mean, and we have nurses and doctors. What are we going to do of those who are not caring about patients who are paying the national health insurance? Are they going to overhaul the system? And I'm going to say this because I had an experience with my 80-year-old mother.
Did you hear Dr. Brennen say that one of the very first things is to strengthen the health system?
Okay, but that should have already been started if they're going to implement the system. That should have already been in place.
He said it has already started.
We should be seeing the results now as you go into hospital. That should have already been something tangible that we can see.
Okay, let him comment on that. It just starts, right?
Yes, and what we also want to say.
When you suggest, what you mean? Because I need to draw an illustration to you. That's why I asked.
I ain't sure I want any specific examples that gonna beat up on the hospital staff.
No, I'm not beating up on the hospital, but it's something maybe they may need to take.
Yeah, but I'm not sure I want this show to deteriorate into any specific examples like that.
It's not going to deteriorate. I'm just drawing an example of improvement that needs to be.
Okay.
Okay, I had my mother, 80 years old. She had suffered a stroke. Okay, a broken hip bone. 5 weeks in hospital. I won't elaborate on that part. She went back into the hospital for another 5 weeks again because she had a stroke. They took some tests and they said that they had to take it away, blood tests and different bone tests. She paid money to have it done. And just over a year now, she has to go through the whole procedure, doing the same procedure again because they don't have any records. The results hasn't came in. They can't find the results. It's just a lot of complacencies within the hospital system. And when she goes there, there's not the same doctor that is taking care of her. And it's just a physical, just a dry run thing. It's not of a concern. It's just a matter of formality and procedure, and that's that. It's not the care that has been taken.
Now I'm glad.
So I'm concerned about that.
Now I'm glad I gave you the opportunity for you to explain. Okay. Thank you.
Thank you.
So, and on behalf of the health system, I would say, I would like to apologize for those issues, occurring, but it is something that we have recognized has long been an issue within the health system, is unfortunately having things such as paper-based records has presented us with a big challenge, because you have to keep track of records, and if someone does show up a year later, you have to find that record. Were the things, if the record is put away and then a test result comes in later, does it get into the record? All of those things become challenges. What we have launched in the public sector is an effort to make all of our records electronic. So we have identified.
You have launched it.
Yes. So we have identified vendors who will be able to provide us with an electronic health record system.
So you have not launched it?
No. But we have started along the lines of being able to take those records and convert them into an electronic form.
Yet?
We are converting at present some of those records into electronic form, right?
So you have.
So we have started the process, is what I was saying, is we have started to convert them from paper to electronic. Do we have a full electronic health record within the public system yet? No, I do admit that. But being able to scan those records and get them into electronic form will also allow us that when we have an electronic health record system to then input those records into that EHR as well.
That can take, 3 to 5 years?
It probably takes closer to 18 months to 24 months to get it fully operational, so that you are the same patient when you present to the clinic, and then you go to a specialty service, and then you go to the hospital. Your records then follow you. But again, you can't just have it in the public sector either. this has to be something that is also something that's able to be accessed in the private sector as well. Because remember, this is national health insurance. This is universal health coverage. We need to have a system by which it's only 350,000 of us. One health record system could handle all of us, no matter where we are. So we need to be able to address it such that all of us are addressed through the system, and we'll be able to follow those records no matter where you are. There need to be portals in the system by which you have access to your own records as well. There are many systems out there.
Not nobody else, though.
No. We're talking about you. Password, security protected, to be able to access your own records so that if you are going to different parts of the system, you will be able to provide and track your own health status as well.
We got to go to the news by one. 2 quick questions answered quickly. Will South Andros, under this plan, get a doctor?
Yes.
Will this cover you if you start going crazy?
There will be mental health services that are provided as well, yes.
This is Darold Miller Live. We'll be back right after the news break. Welcome back to Darold Miller Live here on the ZNS radio and the television networks. We are being sponsored today in part by the 17 shop. And ladies, I can tell you, just like the guys, you gotta look sharp this Christmas. And what the 17 shop is doing is, as they get the new arrivals in on a daily basis now, they are discounting some of the stock that's been around since September, October, a month or two. And so there are some racks, quality clothing, discounted at unbelievable prices. You want to check out the 17 shop, make sure call my name, and they are going to give you a discount on top of the already low prices on the quality wear. What I like with the 17 shop is generations of women can go in together. Your grandmother, your mother, your daughter, you all can go. There's something for everyone at the 17 shop. Guys, you can go too, because you can set aside, lay away, or put a gift voucher so that, the person in your life, your mommy, your sister, your girlfriend, your wife, they can go and take advantage of that as well. This is over at the 17 shop here in Nassau, Collins Avenue, and 4th Terrace. In Grand Bahama, it is downtown Freeport. And don't forget about peekaboo kids. And I found a great place for you to stay if you're coming in from the islands or from foreign as a group to be with us going into the Christmas. You might want to come in from Eleuthera or Inagua, do some Christmas shopping. We have found this great place where it's short-term rental. It's called Gilly's Dream. And it sleeps up to 8 people. You can all stay together. It is really worth it. It's only $200 a night, but let me tell you what it includes. It includes 3 bedrooms, 3.5 bathrooms. It is ideally located. It's got your full-size kitchen. You've got your internet room. It's really unbelievable. You can go on my page. I'm going to post something on my page. It's called Gilly's Dream. Your home away from home. Experience real Bahamian living in a quiet and safe subdivision. It's right off the Prince Charles corridor, so you're not too far from the mall at Marathon, not too far from downtown. 3 lovely, well-spaced rooms, private baths, flat screen TV. They got free telephone calls to foreign. This is really great. Laundry facilities, cable TV, and if the light go off, DC, you won't have to worry about nothing. Most of the system is solarized, so This is where you can come and stay as a group. Now, I'm going to give you the telephone number. You got to utilize this number right away because I think they're getting booked fast. Christmas Day is already taken. So what you can do is make this call right now. Get your pen ready. 557 2555. Let me make sure I get that right number. 557 2555 or 324 6182. 324 6182. This is Gilly's Dream. Wonderful place to stay if you're coming into Nassau. Funerals, weddings, just to go shopping. Even if you live in Nassau and you want to use it as a place for a little retreat, call that number and they will take very, very good care of you. Free internet, free phone calls. Dr. Delon Brennen is my guest. He is the project manager for National Health Insurance. You find that as you get older, you lose your sight. Huh?
It does happen.
I had to pull out my glasses.
I see that.
The print gets smaller. Is that
is
hereditary
normal.
or is that normal?
That's just normal aging.
What is hereditary?
Hereditary, you're talking about in
definition.
Specifics? Oh, it just means that you're able to pass it on from one generation to another.
So you can pass on diabetes.
You can.
You pass on obesity.
You can.
So a lot of these challenges in health, we inherit them from our parents.
We do, but the way in which we find that most of these things will manifest is that it's basically based on a two-hit theory. So you may get a propensity to have it from your parents, but it requires you to have that second hit, such as your lifestyle, right?
My father had quadruple. My brother had triple.
And a lot of that depends on, so because they have had that blockage in their coronary arteries, no, it means you have a propensity toward it. So because of that, because your risk is higher than the general population, you know that you need to take preventative steps to ever getting there. So you may be one of those people that needs to make sure that your diet and your exercise is better than others, that your cholesterol level is lower, that if you need to take aspirin therapy on a daily basis, that's something that you need to pay attention to because you have a higher propensity toward getting one of those diseases. Someone who doesn't have that from their own genetics may not need to be as careful, but if they take it to the extreme and they still don't do some of those preventive measures, even though they didn't have the higher risk, they were still at some risk, and taking their diets to a worse extreme, they're still going to have the same problem.
Let's take some calls for Dr. Delon Brennen. He is the project manager for National Health Insurance, universal health coverage. Ms. Oliver.
Good afternoon.
Good afternoon.
Good afternoon.
Yes, Mr. Brennen, my mother is a cancer patient, and her medication is like $3,000 plus per month. She's on Clevex.
Yes, ma'am.
Would that medication be free under National Health Insurance?
So again, I think we definitely want to make sure the very specifics of each and every medication may be difficult to say right at this time, but under National Health Insurance, chemotherapy and radiation therapy for those people who are unfortunately diagnosed with cancer is included. So there is going to be funding through National Health Insurance that will provide that type of therapy for people who are diagnosed with cancer.
What's the medication?
The medications themselves. So chemotherapy is the medication, and the radiation therapy is just a different type of therapy. So both chemotherapy and radiation therapy would be covered. Yes.
Yeah, because the Glevex is the pills that she take on a daily basis.
Right. It is a form of chemotherapy, and it is very expensive. But again, as you can imagine, as you begin to bring these into a national perspective, you then begin to bring in a pool of people who need to have that therapy. And when you present that pool to let's say a pharmaceutical company that is producing that medication, you're saying that I have this group of people that I need to get this medication for. So it isn't just one individual. You can negotiate on price control, because you can say, if I'm bringing you 100 people on average per year who need this, I'm not going to pay the same price as I would need for one person or two people who would be accessing it. So you bring in the economies of scale of being able to have a nationalized approach to procurement of medications as well.
Thank you.
Yes, can I ask another question, please?
Go ahead.
Yes, and every year she has to travel for a PET scan, I guess, to see the status of her cancer.
Yes.
You know, if there's under National Health Insurance, would PMH or somewhere have that machine that she could do it here?
Right. So under National Health Insurance, we will have a health technology assessment body, whether it's a commission, whether it's an agency, but we'll have a grouping that will be set up to evaluate what technologies we actually need in country right now to be able to get us the type of care that we need as well. As you can imagine, a lot of this is just built on what people are able to afford or what people are willing to invest in as healthcare providers or business people to purchase, but they're not assured that you're going to have a guaranteed source of funding to be able to say it makes sense to make that investment. But if they know through National Health Insurance, a service such as PET scans will be covered, and we'll have a group of people, through National Health Insurance that will need to access our service, then it makes sense to them to invest in such a technology. That will also occur, let's say, at a place like PMH as well, because they'll say, well, since we know that this is going to be covered through National Health Insurance, we have a guaranteed source of funding for this service. Yes, it may make sense for us to invest in the technology because we know it will be paid for.
But you don't have it now.
PET scans? No, PET scans aren't done in country at present. But it is a technology that we know we need to have.
What is PET?
It's positive emissions tomography. So it's it's basically a higher level type of
Elizabeth Darold
CAT
do
scan.
that?
No, ma'am. No, sir.
Tony Miller doesn't do that?
Not as far as I know, sir. As far as I know, PET scans are not available in country at all. It was something that was looked at for its applicability, but because that guaranteed source of funding for those people who needed it was never in place, and people were either paying out of pocket or through private health insurance, and private health insurance wasn't necessarily coordinating how that care needed to happen and getting together to say all health insurance would have been able to point people in the direction of that one, but they were sending people overseas and things like that. What we want to do is be able to coordinate that in one mechanism and be able to say, we can guarantee you there are going to be X number of people who need to access the service. So it makes sense to invest in that technology. Also, you'll avoid the competition for inferior technologies because the HTA will say, for the size population we have, we may need to only have one PET scanner, or we need to have 3 PET scanners. But once we reach that level of 3, we don't end up with 6 of them, because then again, the level of investment wasn't made in the way that it should have been approached.
Thank you for your question.
Okay, thank you.
You're welcome, ma'am.
You a full foot.
Yes, sir.
Why are you keeping that a secret?
I didn't keep it a secret.
You
It just
didn't
didn't come
say.
out. No, absolutely.
You from Turks and Caicos.
Well, along the way, my grandfather was a full Ford, and then my mother was a full Ford. I mean, I've been to TCI, but I've never, I don't
Good
know my
afternoon,
family.
Mr. Miller. I am watching your program now on N.H.I. with your guest, Dr. Delon Fullfoot Brennen. And I must say that prior to him explaining the whole N.H.I process, I was totally against the implementation in January 2016 because I did not understand it. But after hearing him explain it so intelligently, so simple, and understand even the uneducated should understand this whole N.H.I process. I am now fully on board for the implementation on January 1st, 2016. I agree that if we as a people want secondary and tertiary health care, we as a people should have to pay for it. Hopefully, this will cause us to begin taking better care of our health. Dr. Brennen, you are doing an excellent job. This should have been done a long time ago to avoid all the confusion going on now. Keep up the great work. We are proud of you, an intelligent, young Bahamian man.
Thank you. I'm just glad they still consider me young. But
now, I ain't sure who is the writer of this.
Me either.
But
sir.
I believe it is Mark Fulford. You know Mark?
I do not know Mark, but I would appreciate Mark and his comments, regardless of whether it's him or not.
All right, they're telling me they have a special gift for me. Is it still coming? They have a special guest presenting me with a Christmas gift. You don't know nothing about it? They didn't tell you?
Christmas came early.
I think they can bring you one too. So that might take a minute or two before we end our program. Catherine is on the line. Hi, Catherine. Are you there, Catherine? She's not there. 325-5405. From the Family of Islands, it's toll free. 1-242-300-8255. Let's go to some of the text messages we're getting. Mr. Miller, how is N.H.I going to be funded? If the people are going to pay, then how much would each person pay? Or would it depend on one's financial status or income? I think they weren't quite listening.
Maybe not. Hopefully we explained that enough.
Well, in a capsule.
Yeah, we can go quickly again. So in this first phase, there's no new contribution that is coming out of anyone's pocket or salary for this. The government will be paying for that. For all primary care, primary registration.
Small healthcare is how I can call that, so people understand. Not your major healthcare in the hospital.
It's not the high expense healthcare, but it is major healthcare to me, being someone who started out in primary care, because that is where the core of keeping people healthy really is.
Right.
And if we are going to spend money and going to spend time and effort.
Yeah, but now you're presupposing, because see, when I talk about that, if you could be healthy and don't need primary health care.
No, you still
need. No, let me tell you why.
Okay.
You get an accident or you like that boy, you get took up.
Right.
You ain't got to go to no clinic then.
No.
You got to go straight to the hospital.
You do, sir.
So my primary health care is fine.
Okay. Agreed.
But I get stabbed.
Mm-hmm.
I got trauma.
Right.
Wounds. I get shot innocently. I now need major health care.
Yes.
So don't. Let's make sure
now.
No,
I agree with you. We need to keep the separation.
Right.
But I just didn't want us to believe or perpetrate to the Bahamian people that primary health care is not major health care. It is still a large part and forms a large part of what we need to do as a Bahamian side to get ourselves healthy.
While we wait for people to call in, can you ask Mr. Brennen, how will the system combat against the Bahamian culture of people pushing who they know at the top of the list to have their surgeries, etc., from that special fund paid for? And what will be the process in terms of a deciding panel? And how long do you anticipate the process will take from first being notified from the provider that a patient needs the additional service to getting payment to having surgery?
I expect that will actually be a fairly quick process, and I'll tell you why. Because it won't necessarily require a huge human element. There'll still be humans involved, but what we want to do is set up, based on an evidence-based guideline, to have protocols in place ahead of time, such that if you present with A, B, and C criteria, that's how you enter the service. It doesn't require judgment on my part or on your part, who I know, who you know. None of that will be required. It is based purely upon these criteria say you are this level of sickness and you get pushed in. If you are A and B criteria and you need to have it addressed, you may not be at the top of the list, but you're on the list in a certain order because you can wait some time to have it addressed.
I understand your question.
I do.
I'm the politician's son, so I go into the top of the list.
And I think that's absolutely what we want to avoid. Without protocols and guidelines in place, that's exactly how it happens. Once you have them in place, then it makes sense to me, you, and everybody else why someone is placed in a particular order. But as long as you continue to have anarchy or chaos, then there is no order and people get placed because I know someone or I can access it or I can pay for it.
So
but we want to remove that.
happens?
Yes, sir. That is a big part of our job.
You, Dr. Delon, will make sure.
I, along with the people who are charged with that, will do just that.
Mr. Rick is on the line. Mr. Rick.
Yes, good afternoon, Mr. Miller and your guest, Dr. Brennen.
Good afternoon, sir.
Yes, the question I want to ask, right? Okay, I have to attend doctor in the U.S., right? So is National Health Insurance covers anything in that respective in that regards or anything like that?
So National Health Insurance is, again, national in its scope, in that it is covering the services that can be delivered in country to people who are eligible for those benefits in country. Now, if we find there is a service that cannot be delivered in country, that needs to be delivered to the population and can only be delivered outside of the country, then we look at financing those services. But if it is your choice to choose to see a provider outside of the country, but you could access that same service, quality service in country at a level that it should be delivered, then no, National Health Insurance will not pay for you just because it's your choice to see someone outside of the country.
What I meant, I had a procedure done a couple of years ago in the U.S. and every 3 to 4 months, normally I go over to check up and make sure everything is okay. Everything is going well. So I meant like that. Do you all cover like the doctor's visit and because there's something done prior or before National Health Insurance, so you all wouldn't be able to take that role on.
Like a grandfather.
It is very unlikely that would be covered. And especially when it comes to follow-up procedures and things of that sort, it is much more likely that type of service would be able to be delivered in country through the high-quality professionals we already have in country. So we should be able to do it that way.
Thank you, Mr. Rick.
Okay, thank you.
I'm a Haitian. Do I get N.H.I?
Are you legally resident in country?
I got paper.
So you are a work permit holder, and you just happen to be of Haitian descent, then yes, legal resident population in the Bahamas, whether you are from Haiti, from the United States, from Canada, from the UK, as long as you are contributing to the system, then it is likely that you will be covered for N.H.I. as well because you have paid to be covered under N.H.I.
You lost me there. You're saying I must pay national insurance?
So you pay a work permit fee when you enter into the country. So any work permit holder pays a work permit fee, right? Or someone pays it for you, nonetheless. There's likely to be a surcharge based on work permits This is something we're working on now, but what has been proposed is that there will be a surcharge on work permits that will be essentially equal to the annual amount that is contributed on behalf of anyone who is in the country for it. So let's think of it as like a premium. Let's just make it simple.
Let's say the work permit is $1,000.
Right. And let's say the amount that would be contributed on behalf of any resident in the Bahamas would be $1,000, right? So the work permit holder would now pay $2,000. So their original work permit fee and the $1,000 in order to be an N.H.I. Yeah, but that's how much we're paying. So if the government is paying on your behalf into N.H.I. $1,000 per year.
Oh, this is per year. Go ahead.
Per year, right? Mm-hmm. And the work permit holder comes in, then the expectation is their contribution per year into the system would be at least the same amount that's being paid for everybody else. So that would be the same 1,000 in this illustration.
Okay, so I'm here, I'm not working. I'm the work permit holder's wife.
Okay. So
I'm not working.
But they still have a permit to reside in the Bahamas.
Annual residency.
Let's call it annual residency. So there would still have to be a fee paid on that person's behalf to be in the system as well.
Who will pay that fee?
Whoever, when the work, so the same
Who will
time.
match that? Because I ain't working. Sound like you're saying
No, but it's not up to you.
Employer.
No, but whoever is paying the work permit fee is paying for that.
There's no work permit in this new scenario I just bring.
No, that you're saying that's the resident. I mean, that's the spouse of a work permit holder.
Right.
So there is a work permit involved with that person. So the fee would have to be paid at the same time as that person gets their legal resident status as well.
Okay. There are cases where there are no work permits involved.
So they
just
have
residency without the right to work.
So if you are resident without the right to work, that is something because there will still have to be a fee paid for each one of those people as well, because obviously they can't write off the system.
Where I'm going, there's no matching of it.
No, we're just talking about it has to be paid by whomever. It may not be an employer. They may have to pay it somehow out of pocket or whatever, but it still has to be paid.
Have you considered all of these?
No, absolutely.
Now?
That's something that's what I'm saying. This is the model that has been proposed and is being finalized with the assistance of the Office of the Attorney General and Immigration. We're all working together to ensure that the legality around this is all very tight as we roll that out.
My children now, the work permit holder, my children covered?
There would still have to be a fee paid for them as well, because obviously you can't just bring your children in, expect them to be able to benefit off of the system without something happening.
Now. The hospital full up with illegal immigrants now.
It is not full of
Don't
illegal
tell
immigrants.
Me, man.
Absolutely, sir. If you look at the actual statistics, the people who access health services in the country are legal one. But what I will say is there is a percentage. The last time I looked at it, it was 12% of hospital admissions were to those
I ain't talking admission.
Who access hospital services. We're talking about, it's actually discharge, but nonetheless, we're talking about people who access health services at the public hospital. That number is made up of 12% of people where their legal status is not documented.
Okay.
So we'll assume they're all legal. They don't have to all be illegal, but we're saying their legal status has not been documented. That only makes up about 12%. So it's not full of illegal immigrants. There is a percentage, but it's not full.
Pat.
Good.
Hi, Pat.
Hi, Darold. Can you hear me?
Yes.
Good afternoon to you and to Dr. Brennen.
Good afternoon, ma'am.
Darold, I'm so happy you have talk on today.
He's smart, eh?
Yeah, and he had up with you, Darold. I mean, you meet him out today.
And he ain't got no paper in front of him.
Are you serious? That's excellent, and one of the son of the soil. I'm so proud. But, Darold, I just want to ask the good doctor a question in reference to the National Health Plan. Doc, in reference to now they have the prescription drug plan that's available to, I think, children and the elderly.
Well, there's a whole group of different people. So the armed services get to use it. There's a whole group.
Okay, well, is that going to be included in the N.H.I. when it rolls out in January for everybody? Can everybody be able to take advantage of that?
Yes, ma'am. So essentially what will happen is the services that are now provided under the National Prescription Drug Plan will be enveloped or amalgamated into the National Health Insurance Program. So it won't look exactly the same, but the same services that those that smaller proportion of the population is able to enjoy will now be extended to the entire population. So when N.H.I. rolls out and we're providing primary care services, those drugs that are now provided under the National Prescription Drug Plan that would count as primary care drugs will be included in it. And so everyone who is as a registered beneficiary of National Health Insurance will have access to those drugs from the instance. When we get to the full vital benefit package, and all of those drugs, plus others, are now included, then everyone will have access to the entire list of drugs through National Health Insurance.
Okay, great. Thanks. That's
You're
great.
welcome.
Thank you, bye.
Thank you. Bye.
Okay.
Have a great one.
Mr. Miller, I'm a young college student. Who care deeply about the future of my country. I must admit, prior to your show today, I was totally against it. Thanks to Dr. Brennen, clear and sincere responses and explanation, I am fully on board and will encourage my fellow college peers to do the same. My N.H.I. number is...
We don't need your exact number.
I can get it. I get it. People might wonder. 12016. This is Travis Robinson. First time texter. Hold on, Ron. Health information is very super sensitive in a very small country like the Bahamas. How will data be assured to be protected once we go electronic? We cannot afford for health information to be leaked. Keep that in your head. I can read a few more.
Yes, sir.
And go to if money for N.H.I. coming out of national insurance, what happened to people's pension? You gotta dismiss that one.
Absolutely.
Brother Miller, I spent 2 days getting a new NIB card this year. And now I have to go through that frustrating process again. If the cards have chips in them, can't NIB simply program our cards in their systems?
Yes.
Good day. Please ask Dr. Brennen if the government will now cut back on the imported foods that are making our people sick. We don't want to perpetuate the vicious cycle that now exists. We import foods that make our people sick. Then we pay for their treatment and medication. We must place emphasis on prevention and the reversal of certain ailments. That's one coming from a proud Fox Hillian. Brother Miller, I want to know, what if we need further treatment abroad or get injured in foreign, where hospitalization is more expensive? Good morning, Mr. Miller. I would advise people to keep their personal health insurance because this N.H.I. appears as if it's for minor medical care and not critical medical care. We got to dismiss that one right away.
Agreed.
That's why I asked you, but the quadruple. That's one of the most expensive.
It is very expensive.
Your heart blocked 5 places, the arteries, and you need a bypass on each one. Cut your chest open. The best doctors only could do that. My father had that. sometimes I can be bigoted. I call for it. I call the hospital where the President of the United States would go to. I say I want to know that the best doctor will operate on my daddy. Who is the best doctor in the United States? Fella say, so where you calling from? So I calling from Nassau, Bahamas. He said, the best doctor trained me. And he's right there in Nassau, right around the corner from you. He said his name is Dr. Darold. The best in the world. I can put you on. I'm serious.
Thank you, sir.
We have the best doctors in the world right here.
We do have quite a few of the best in the world, yes, sir.
This is Darold Miller Live. We'll be back right after these messages. Welcome back to Darold Miller Live here on the ZNS Radio and Television Networks. We are proud to have back on board as one of our sponsors, Twin Brothers, the world famous Twin Brothers at the Fish Fry on Arawak Key. They are offering 25% discount for Bahamians who dine in their restaurants on Arawak Key. If you see me, you can get these cards. You can go there and get them. 25% discount off dine-in for Bahamians. This is Twin Brothers Seafood and Daiquiri, located at the Fish Fry Arawak Key. You don't need reservations, but if you want to call, sometimes it's good to have reservations. 328-5033. 328-5033. You know Twin Brothers. You've been trusting them all along, but lately you haven't been going. You've been stuck in them web shops, and you've been doing foolishness. Take a break from the web shops until after Christmas. Go to Twin Brothers, dine out, enjoy that nice scenery with the cruise ships and all of that. Get you 25% off. If you see me, I'll give you these cards. But they're offering that for you. Great, great food always at Twin Brothers. You've eaten there before.
I sure have,
Just
sir.
about every Bahamian.
Oh, yeah, what you mean?
But then we stopped lately. We've been distracted. That's why there's so much elevator in our lives, the ups and downs, the vicissitudes of life. We have to take a break and conquer them. The web shops are woo. And then the other things, the gangbanging, the just trying to get a job. Bahama. People out of work. But there is hope, folks. Take a break. Say a prayer. Everything will work out just all right. Twin Brothers offering you, that's not part of the ad, but I had to get it off the chest. Delivering you excellent seafood and daiquiris, 25% discount. Anywhere you see me, I can give you these cards. I mean, you know, if you get a meal for $20 and 25% off, this card is worth, $5. Then I want to tell you about GAP Property Maintenance. It's time to fix up around the house. You've been trying to do it all year. Again, you've been distracted. Christmas coming, people coming to your house, fix it up. You need a little small repairs, little masonry, little carpentry, and other maintenance and repair works done in a professional and timely manner. Call this telephone number, 322-4609, 322-4609. GAP Property Maintenance. They'll give you a quote on the work you need done, including materials and labor, and they're going to jump on it right away, finish it. No job too big, no job too small. They'll have it finished for you for Christmas. GAP Property Maintenance, 322-4609, or you can call Mr. Frank Hanna for the hookup with GAP Property Maintenance. Frank Hanna at the Frank Hanna Cleaning Company, 323-4531. One other thing I want to say. I know you telling me you're busy, but you got to eat. After talking for 2.5 hours. I don't know about you, my stomach growling. But what we can do is go to Divine Cafe. I know you're busy. Maybe you could take it out or something. Order it and take it out. She got the baked turkey. She got peas, soup, and dumpling. With the wet weather is a soup day.
Mm-hmm.
They got sauteed shrimp as well, and the barbecue chicken. You got a good choice. If it were Friday, I'd tell you peas and grits. But that's tomorrow.
Yes, sir.
So, by the way, tomorrow, that's menus at Divine Cafe, by the way. The telephone number there is 394-2829. We're going there directly after the show. Hopefully, you could push something back. Or have,
I already pushed it.
Have Portia bring
There you
something.
go. There you go.
Portia wants a pea soup, I think. So Portia can deliver something to you wherever you are. Okay. Tomorrow, we have a big concert coming up tomorrow night in aid of Hurricane. It's postponed to Ready. Rather, okay. All right, because I was going to talk about that a little bit. Okay, thank you, Ronald. Ronald is on top of things.
I see that.
But we do have a lot of things to talk about tomorrow. God has put in my heart some things. That's why I invited Bishop Walter Hanschel to come on the show. And he is called for addiction centers to be established right next door to the web shop. Because we are losing a lot of our people to the scourge and sickness of gambling. We're losing a lot of people. I asked you this before, but you gave me the short answer. I want the long answer. If you need Sandilands care or some other expensive mental care, you need to see Dr. David Allen with N.H.I, National Health Insurance, cover that.
Yes. So we do have mental health services covered within the benefit package for National Health Insurance. We want to make sure that when we consider non-communicable diseases and the issues related to the high morbidity and mortality in country, we think about those things like heart disease and diabetes and and some of the respiratory diseases. But what we have not necessarily focused on at the level we need to is the mental health issues. Mm-hmm. And in this instance, we want to make sure that we don't forget that. So we have very specific targeted services and payments for mental health services, both on the inpatient, but even more importantly, for outpatient mental health services.
Are you shocked to see the amount of crazy people walking these streets?
I am shocked to see the very high levels of mental health problems and illness that does occur. I mean, the
other day, I was so embarrassed. He stood up the other day, man, and he take his pants down and let his thing hang out in the road. We got to do something about that, man.
We do, sir. We do. And I think the thing is, it's decreasing some of the stigma related to mental health issues and being as family members who recognize that there is a problem. Because a lot of times, obviously, the people who have mental health issues don't recognize it themselves. But being able to say, I recognize it, and I will help my family member get into service is what is most important, because that is how we're going to do it. As communities and as families, that's the only way we're going to really get some sort of handle on the type of mental health issues we have in this country.
Late in the night?
I try not to, sir. I have a family and children.
If you're coming from a banquet or something,
yeah, then I understand that part. I do see
people
lots.
Naked, man, walking in the middle of the road naked.
Yep. Absolutely.
Mind gone. They ain't got nowhere to live.
And it's definitely higher than it used to be.
They defecating all over the place.
Yes, sir. We see it all the time. I think it's something that we as a nation have to stop thinking about it as it's them and they have a problem, and we have to realize it's us. These are our children. These are our mothers and sisters and fathers and sons. This is us, and we have to accept it in order to make sure they get the care that they need.
Man, you gotta cut down.
I'm always willing, sir.
2.5 hours. You can't.
You know, you say that ain't long enough.
Man, listen. You need to be on it. If this thing starting January 1st,
Sir, I say
you need to be on once a week until then, and then you need some big town meetings.
Yes, sir. Absolutely.
Then we gotta cover because everybody ain't here to show you.
No.
It's 350,000 of us.
Yes.
If I had 50,000 listening today, I'm lucky. We gotta go to Great Harbor Key.
Yes, sir.
We gotta go to Salina Point.
Yes, sir.
We gotta go to Cabin Hill where they even got no light.
Very true. Very true.
We must go to Deep Creek. Spread this message.
Agreed. We have to let the people know what it is that they can expect, what they can be realistic in their expectations about, and we have to hear from them and say, what is it that you need out of this? Because I think that's been missing in the conversation, is we've been hearing from, stakeholders in the industry, and we've been telling what we propose to put out there. But what the Bahamian people aren't hearing from each other is what their needs are, and we need to be able to let them know. Because people ask us all the time, why are you starting with primary care? This whole catastrophic thing needs to be front and center. But the interesting thing is, when we went to the people and asked them what they wanted, they told us they wanted good, quality, respectful primary care services, because that's what they attach every day. There's only 6% of our population that needs hospital level services in a year. But 100% of our population needs primary care services every year. That's where we have to start.
Dr. Delon Brennen, thank you.
Thank you, sir.
God bless you, sir.
Thank you, and God bless you as well.
God willing, I'll be back tomorrow with another lively, provocative Darold Miller Live.